Hello, everyone. It's nice to see you all. I'm Brian McCourt on behalf of the entire foundation. I'd like to welcome you here to the 2024 Neurological Symposium. It's hard to believe that this is our 21st symposium since starting the foundation. And we are proud to have two presenting sponsors, UBS and Eisai Pharmaceuticals. Thanks so much for all your generosity. Also thanks to our other sponsors, Biogen, Genentech, TG Therapeutics, MT Pharma. As you all know, they're here today, and if you stop by, they've got some great resources for all of you to learn more. The foundation's mission is striving to cure neurologic diseases while empowering others to build a healthier world. And this is built on three pillars. One is research, second is education, and the third is partnerships. And what we do with this is obviously research. We help fund research and these fine institutions that are our partners. In addition to that, we partner through all of our events and allow other nonprofits that are health-related raise funds and awareness through our events. So the last thing again, though, is our educational pillar is extremely, extremely important. And today we have, through the broadcast, we have 11 countries, 25 states, and over 212 cities and towns tuning in. So what that really tells us is the importance of this education and connecting with these physicians, some of the finest in the world. And these doctors, they donate their time here. So thank you so much for all you do, and thanks for being such a good partner. Also, thanks to our team here in Boston, Rosemary, Kelsey, and Matt, as well as our team out in LA for making this all run. We appreciate everything you do. Now, I want to introduce a good friend, Dr. Eric Clowwitter, and the moderator of our first session. Dr. Clowwitter.
Thanks, Brian. This is always a highlight for me to be able to share the recent research and updates as it relates to multiple sclerosis. And the McCourt Foundation has been a great partner over many years. I have the pleasure to moderate the Neurological Symposium MS session this morning. We have three really, I feel, excellent talks in store for us. Following those three talks, there'll be ample opportunity for question and answers. So as you're listening to each of the talks, think about questions that they may stimulate. Following the three talks, there'll be a Q&A time where we'll take both live questions, but also if you feel that you have a burning question but don't want to ask it live, there'll be someone circulating and taking those questions, which will be brought up to me on stage. Our first speaker is Dr. Tanuja Chitnis, who co-directs the MS Center at Brigham and Women's Hospital. She also directs a longitudinal natural history study that's generated, I think, over 200 publications in the last decade called the CLIMB study. And she'll be presenting some of that work from the CLIMB study related to biomarkers, but also some promising clinical trial work that she's doing in progressive MS. So, Dr. Chitnis, please.
Great. Great. Well, thank you very much, Eric, for the introduction, and also to the McCourt Foundation for the opportunity to speak to all of you, and really for putting on this world-class symposium. So it's a pleasure to be here, and I look forward to sharing some of our work with you. For some of you, you may know of me, but I've been working in the field of multiple sclerosis for over 25 years. I have about three main jobs. I see adult patients at the Brigham MS Center. I co-direct the center. I see pediatric patients at the Massachusetts General Hospital, where I started a pediatric MS center over 20 years ago. And I also do a lot of research in multiple sclerosis. And all of these are my passions, and I'd like to share some of our updates with you. So I'm going to cover three topics. One is blood biomarkers for MS. The second is new treatment strategies for progressive MS that we're working on at the Brigham, and also progress in pediatric MS. So first, I'm going to start with a topic that you may have heard about. This is something that is emerging certainly in the scientific MS community and starting to be used in the clinic. And this is the topic of blood biomarkers. So what we do know that in MS, when there is a new enhancing lesion with a relapse, then there can be neuronal or axonal damage, or neurons can be damaged. And those neurons or axons can release small particles or proteins that can accumulate in the spinal fluid, but also now we find them in the blood. And those can be markers of a new relapse. So this is a discovery that was made about 10 years ago through the work of a number of scientists around the world. And it's really coming to fruition where we're starting to be able to measure these very small quantities of proteins in the blood using advanced assays. And so one of these proteins is called neurofilament light chain, or NFL. And so you're going to hear a lot about NFL. It's not the NFL that we all know about and are going to watch tonight, but probably that's also relevant to NFL and sports. But neurofilament light chain is a particle that is part of axons, and now we can measure them in the blood. And this is through the advent of a number of very highly sensitive assays that use advanced techniques to measure small quantities, such as something called a single molecule array or Simoa assay, another assay called the proximity extension assay, and then other chemiluminescence assays. So, we're starting to see in the neurological field a lot of blood biomarkers being used across diseases in Alzheimer's and head trauma, but also in MS, and this is through these advanced assays. So we've been doing a lot of work looking at biomarkers in our CLIMB study using assays like this. So what's been learned is that NFL is elevated across many neurological diseases. So it's not specific to multiple sclerosis. It is elevated in Alzheimer's and Parkinson's. If there is head trauma, it's elevated, and also with acute new lesions or relapses in multiple sclerosis, it can also be detected. Unfortunately, it is also detected in head trauma and in the context of chronic traumatic encephalopathy. So I think this is something we all have to be aware of. So what has been discovered in MS is that this particular protein, NFL, is found in the spinal fluid, but through very sensitive assays, we can measure it in the blood, and there's very good correlation between the two of them, and this is what some of the recent work has shown. Also, this protein in particular correlates with the number of new gadolinium-enhancing lesions on brain and spine MRI, the number of relapses that are going to happen in the next 2 years, and also the number of T2 lesions, and you might say new lesions that may happen in the next 1 to 2 years. So this is something that's very exciting and promising, and NFL is now being explored for use in the clinic. It might inform MS diagnosis. It might help to monitor the response to disease-modifying treatments. And, as part of a response or a monitoring program for what we call DMTs, or disease-modifying treatments, you come into the clinic every couple of months, you have an MRI every 6 to 12 months, and this might be an addition to help to tell the doctors whether things are really quiescent or suppressed on that particular drug. So there is a lot of promise for this particular blood biomarker in that context. It could also be used to check for new relapse, new lesions that are maybe occurring, and also monitoring after treatment discontinuation. In some instances, we might need to discontinue treatment or even de-escalate and use fewer doses or lower doses in certain contexts if there are infections happening. And so this could be another way to help doctors monitor what's going on with MS. There are some considerations. There's always caveats, and there are limits to the sensitivity and specificity that we all have to be aware of. It's increased in other diseases, so we need to check that there's not something else going on, like head trauma. And I will say that this right now is not an FDA-approved test. It is coming. There are a number of companies that are working on this particular protein for FDA approval. So it is very exciting and a hot topic. Another protein that is being studied is something called glial fibrillary acidic protein, or GFAP for short. And this is produced by astrocytes. Now, astrocytes are sort of the supporting cells in the brain that are helping to support the neurons and the axons and feeding them good nutrients and helping to support them. Sometimes these astrocytes can become inflamed and not do their job and also start to produce proteins and factors that are in fact deleterious. And there are a number of studies that have shown that some of these proteins, including GFAP, that is produced by dysfunctional astrocytes, is associated with progression in multiple sclerosis. And so now there's been a lot of work, and this is our work as well as international work, that it's pretty much agreed that GFAP is elevated in progressive forms of multiple sclerosis. It's not the only protein, but it is one of the main proteins that is elevated in progressive MS. And levels of this GFAP might help to predict whether someone needs future gait aid or assistance with walking. So we're now using and studying GFAP as a prognostic biomarker. And this will help us to predict which patients might need further interventions, might be more appropriate for certain treatments, and also whether they are in fact entering the progressive stage of disease. So again, this is not FDA approved, it's still in development, but it's very exciting that we can have additional ways of helping to tell us where someone is in their disease course. So this has also led to the development of what's called multivariate proteomic assays, where we're testing thousands of proteins in a discovery set to try to figure out, is there an even better way to detect new relapses, new lesions, disease progression. And this is a lot of the work that we're doing in the CLIMB study, which is a longitudinal study that's been ongoing for over 20 years at the Brigham that I direct. And in this study, we have studied a number of cohorts of people, and we found that additional proteins help to increase the sensitivity of detecting new lesions, new MRI lesions, and new relapses. 18 proteins are available in something called the Octave MSDA test. Again, this is a laboratory-based test. It's not FDA approved, but it is being offered in some clinic settings. So I think we're going to see more of this, these sort of multiple proteins in one test, and we're hopefully going to get to a place where we have better sensitivity and specificity for all of these questions that we're asking. Is there a new lesion? Will a new lesion happen? Where am I in the disease course? Is this progressive MS, or will progression occur? Okay, so that's one topic. So the second topic that I want to share with you is some of our work for progressive MS treatments. And so as we know, there are really no treatments approved for non-active secondary progressive multiple sclerosis. And this is one of our biggest needs. I've been seeing patients for over 20 years, and this is one of the biggest challenges we have in the clinic is how can we treat you with slow progression, stop progression? So we've been studying a drug called nasal ferralumab, and basically what this is it's a molecule called anti-CD3, or an antibody to something called CD3, which is present on T cells. And Dr. Weiner, who I work with very, very closely, in his laboratory studied this in a progressive model of multiple sclerosis. And you can see this little mouse here, and that this drug was given nasally to this mouse. And it was really quite remarkable what happened, because in this progressive model of MS, it slowed progression, not when it was given, or not it didn't need to be given at the beginning, but when disability was starting to occur in the mouse, then this slowed progression and improved disease scores in this mouse. So the right panel also shows an improvement in myelin, or a reduction in myelin loss with this Luxol fast blue stain. And then there's a lot of biology going on in the background where these astrocytes that I told you are the supporting cells, and also microglia, which are another supporting cell in the brain. These are particularly activated in progressive MS and dysfunctional. They were calmed down by this drug in the mouse model. And so we were able to show through gene expression arrays that these cells were actually better. And so then I came in and we said we really want to translate this drug and to try to see if it works in people. So we undertook something called a phase 1 study where we gave this drug to a group of volunteers, of non-MS patients, healthy controls, in 3 different doses. And we found that the drug was actually very well tolerated. These patients, or these people, had the drug daily or every other day for 5 days, and there were no adverse events, and it was very well tolerated. So that was very good. And we did find some improvement on some of the immune scores that we were interested in. So that was our phase 1 study. And now we have embarked upon something called an expanded access program, where we've been giving this drug to MS patients, to progressive MS patients. And our first person who was in this expanded access program was a 62-year-old man with a diagnosis of secondary progressive MS, who'd not done well on all the other treatments, was still progressing, and he was started on the drug in 2021. And we monitor something called the PET scan. So TSPO PET is a way of imaging activated microglia. So remember, those microglia are one of those cells in the brain that are dysfunctional in progressive MS. And we found that the drug, and giving this treatment, suppressed the activated microglia, which we could measure by the PET scan. So that was really remarkable. And we were really enthused about this. And as well, this patient was feeling better. Now, this is what we call an open label program. We don't have a comparator. We don't have a placebo control trial. So, he felt better. Some of his measures were better. He was certainly not progressing or worsening, and we were very encouraged by this result. We've since treated 10 other patients, and we've seen in the majority of them suppression of the activated microglia on the TSPO PET scan. And you can see the 6-month PET scan showing less red and blue in this other individual. So we're very encouraged by this, and we feel that it needs to move forward into clinical trials. So now we've launched a phase 2 clinical trial where we have 54 patients who will be randomized to 2 different doses of the drug and placebo. So we'll be able to really scientifically determine whether there is an effect on this PET scan. And we have 6 centers involved, including our center at the Brigham, and collaborating with MGH. And then there's also potential of this drug for other neurological diseases. So we're very encouraged by this program. So the last topic I'm going to tell you a little bit about is pediatric MS. So MS does occur in children as young as age 10, even very rarely as young as age 3 or 4, and I'm currently treating a 6-year-old in our clinic. And so pediatric MS is something that I felt very passionately about for many years. There was really no treatment centers for kids with MS many years ago, so I started a pediatric MS center at the Massachusetts General Hospital. And this is a picture of some of our staff over the years. We have a wonderful team, including a family counselor, psychologist, and neuropsychologist, and we work closely with our neuro-ophthalmologists and therapy groups. So we have been focusing on a number of areas in the pediatric MS clinic, and one is getting treatments for children with MS. And currently there's only one FDA-approved treatment for pediatric MS, but I'm working with a number of groups, both nationally and internationally, on launching clinical trials for pediatric MS. So this first drug that was approved for pediatric MS, fingolimod, this was based on a phase 3 trial of fingolimod compared to beta interferon, so interferon injections. And this was the mainstay of treatments 20 years ago, even as recently as 10 to 15 years ago, because we didn't really know which treatments would be safe. And so we had to do these trials in pediatric MS to show and determine which treatments are effective and safe in this young population. So this had a really remarkable result. There was an 82% reduction in relapses in the fingolimod arm compared to the beta interferon arm. So that was really remarkable. And I like to tell my families, that only 14% of the children on fingolimod had relapses compared to almost 60% on the interferon arm. So really a remarkable difference. And then this drug was approved by the FDA for pediatric MS, and it's approved in many world regions as well. So I've been working with a group called the International Pediatric MS Study Group, and we're very invested in helping to launch new trials in pediatric MS. And you can see on the green, there's a number of trials that have now been completed, and these drugs are approved in different parts of the world, mainly in Europe. The FDA is still weighing in, and there are a number of trials that are ongoing for some of the newer therapies, including the B-cell targeting therapies. And we were slowed down a little bit during COVID, but we're confident that we will get some of these new therapies completed and approved for children with MS. So this is a picture of the International Pediatric Study Group, and I've had the pleasure of being a chair for it for about 8 years. And I'd like to thank you for your attention.
Great. Thank you, Dr. Chitnis. And again, if you have questions, we will take them at the conclusion of the 3 talks. The next speaker I have the pleasure to introduce is a colleague who is joining us remotely from Los Angeles. Dr. Nancy Sykott is the chair of neurology at Cedars-Sinai Hospital and directs the MS and Neuroimmunology Center. She is going to give us an update on proposed changes to the diagnostic criteria for multiple sclerosis. So please, Dr. Sykott.
Well, good morning, and thank you for that introduction. It's a pleasure to be here. I'm hoping one of these days I'll be there in person and able to see you all. But I'm coming to you from my home in Los Angeles, where it's still early in the morning. But I'm very excited to be here, and I enjoyed Dr. Chitnis's talk, and I'm looking forward to the question and answer period. I hope you can all hear me and see my slides. Just recently returned from the biggest MS meeting that took place in Copenhagen. And one of the exciting features there was information presented regarding new diagnostic criteria for multiple sclerosis. So I'm going to give you a little bit of an update and talk about some of the imaging biomarkers that are now increasingly part of our diagnostic armamentarium. So as you know, multiple sclerosis is difficult to diagnose for anyone who has gone through that process. It is what we call a clinical diagnosis, meaning that there isn't one particular biomarker or test that can be done definitively to give a diagnosis. This keeps our MS specialists busy, and also our expertise is needed. I'm going to tell you a little bit about how neurologic disorders have evolved, and this, I think, will be important and relevant to your future discussions for the rest of the day on things like Parkinson's disease and Alzheimer's disease, which really, at the end, were diagnosed by pathological specimen. And here you see Charcot, who is, as we think of him, the father of neurology, but he described one of the first cases of multiple sclerosis, and he did that by looking at pathological specimens. So not very much help during life if you have to wait until someone has passed in order to be able to make the diagnosis. But he made some seminal observations which have come to be able to now, using advanced imaging and even now some blood biomarkers, as you heard, make the diagnosis in life, in vivo, which is very important now that we have therapies. So the second phase of a neurological disorder is looking at the natural history and the clinical presentation. So this is a cartoon that's used frequently, very complex, as you can see, but this shows the different phases of multiple sclerosis. And what you can see that I think is striking, if you look to the subclinical phase, is that there is a period of time, if you see the green arrows, where there is disease activity that is happening in the absence of clinical events. And the only reason we know that is because we have the tools now of imaging, of MRI scans, that we can look at and see that people are having these very characteristic changes in their brain and spinal cord, and sometimes in the absence of symptoms. This is called radiologically isolated syndrome. And now with the new diagnostic criteria, we're increasingly diagnosing this as MS because we can now follow these patients in life and see that many of them do develop the clinical presentations of MS. But previously, we were limited by looking at clinical events. So you can see the next phase is the monosymptomatic. That's when someone has their first attack of neurological disability or symptoms. And this period of time then brings them to the attention of neurologists. So previous diagnostic criteria had to wait until a second event had happened. And you see that in the relapsing remitting phase. But what's very important to understand is we know now that there's a lot of inflammation that's happening in between those two periods of time, as you see from the green arrows, indicating that there is disease activity that's happening in the absence of clinical events that could potentially be prevented. And then you see as the clinically definite MS was in that second clinical event and then on to progressive MS. So what have we done to make some progress in terms of this diagnostic procedure? Well, if you look back, originally this was all exam-based. So the Schumacher criteria came out in 1965. Then the Poser criteria in 1983 used for the first time MRI and evoked potential, so paraclinical evidence. And then now in the McDonald era, we're really evaluating those patients that have one event, and then we're seeing the increased role of MRI. So really the hallmark of diagnosis has always been that what we call dissemination in time and space, meaning that there's two different events, and previously those two different events had to be clinical events. Now we can use this imaging to give us the diagnosis of dissemination in time, seeing a new MRI event, but also with some of our biomarkers now with spinal fluid, that can be used to give us evidence that there's ongoing activity related to dissemination in time. So the two areas that are important are dissemination in space and time. And increasingly, we've moved with the McDonald's criteria to using our paraclinical or biological tests that we can do in life to make those determinations that we're dealing with multiple sclerosis. So here is one of the MRI criteria that we use called dissemination in space. And this identified classically 4 different regions within the central nervous system that were, you needed 2 out of 4 in order to satisfy dissemination in space. So that includes, as you see with the red arrows, lesions that are in the lower part of the brain, the infratentorial region, lesions that are right next to the cortex, juxtacortical, and lesions that are in the periventricular space. So those are the 3 areas within the brain. And then the 4th location classically was in the spinal cord. So in order to have dissemination in space, you needed to have lesions in at least 2 of these 4 regions. And then in terms of dissemination in time, it would be either a new lesion or positive spinal fluid. So here, I think, is a very telling example of what has happened as we've moved from this clinical diagnosis from the Poser period now down to the newer versions of the McDonald criteria. And what you see here on these graphs is the median time to diagnosis in months. So this is from the time that someone had their first clinical event and the time that a diagnosis of multiple sclerosis was made. And you can see that in the Poser area, it was 20 months. So this is almost 2 years after the first event when a diagnosis could be made. We know now that this 2-year period is a time of lost potential for preventing disease activity and disease progression in the long term. And as we move through the McDonald criteria era, you can see that this median time to diagnosis is getting shorter and shorter and shorter. So we're now in the 2017 to 2020 era, we're down to 4.5 months for median time to diagnosis with the new criteria. And this represents a 77% reduction in the median time from the first clinical event to MS diagnosis, which is remarkable and very important. And why is this important? Because now we have therapies, and we know from the trials that have been done that the sooner that the therapy is started, the better the long-term outcome is. This was always the hope of the new disease-modifying therapies, but we now have data from over 20 years of use that early treatment does increase the likelihood that patients will have less disability when they as they age and as they go on in their disease course. And in fact, we know from the clinical trials that even delaying treatment by as little as 2 years creates a permanent decrease in the outcomes for patients whose treatment was delayed. So moving from 20 months to 4.5 months is very, very important for improving patient outcomes. So there's a new proposal that has been presented when we were in Denmark by the group, the International Advisory Committee on Clinical Trials in MS. They got together with ECTRIMS and the National MS Society, and they convened a group of experts to determine the new criteria for the development for diagnosing MS. These recommendations were met by consensus, and the goal, as always, is earlier but also more accurate diagnosis. And you'll see some evidence for why this is important. So these initial findings were presented to our international meeting group, but the paper itself has not been published, so we're waiting for the final manuscript. But we did get some proposed changes that were very interesting and exciting to think about and to look at. So one of the big changes for the new criteria will be that the optic nerve can serve as a 5th location to demonstrate dissemination in space. This is very helpful because we know, and for those of us who treat MS, that the optic nerve is very frequently involved in one of the first areas that patients have symptoms, but it wasn't included as a topography in making the diagnosis. The other kind of interesting thing is sort of the final move away from clinical to a biological basis for making a diagnosis, and that is that MRI lesions are required in order to fulfill a diagnosis. Again, this is the proposal. So we know that patients can have symptoms, nonspecific symptoms, but in the absence of MRI lesions, objective signs of inflammation, that would no longer be able to fulfill the diagnosis unless they are the typical clinical events that you see. Sorry. So the other really interesting piece of new data and new suggestion is that the radiologically isolated syndrome, what I showed you before, where patients are having evidence that they have inflammatory activity, but no clinical events. This can now be diagnosed as MS if you demonstrate dissemination in time. And the reason for this is because of work that's been done, again, painstaking work of following cohorts over time, but the realization that about 80% of these radiologically isolated syndrome patients will eventually develop a diagnosis of MS. And because we know that an earlier treatment results in better outcomes, these patients now can be diagnosed before they have actually had a clinical event. So in some ways, we might think about this as preemptive treatment to actually prevent a diagnosis of MS. Or clinical events that we see in MS. So that's exciting that we could actually intervene at a time and prevent any disability from developing in patients at risk. The other recommendation was to validate another CSF biomarker to be used instead of oligoclonal bands. This is called kappa-free light chains. These are easier to measure. They have less subjective bias, and they seem to be as sensitive or just about as sensitive as oligoclonal bands, which are the classic measure of inflammation that we've used in the spinal fluid. So also an exciting potential advance. And then from our perspective at Cedars, we're very involved in these new imaging biomarkers, including the central vein sign and paramagnetic rim lesions. And these have been added as additional measures that can be done to increase the specificity of the diagnosis. And this is something we've been very interested in working on to prevent misdiagnosis of MS, which is a fairly common problem now that we're making this diagnosis so early. And we're excited that these are now included as not required to make the diagnosis, but can be used to increase specificity. So why do we need to increase the specificity of our diagnostic criteria? Well, work that Marwa Casey did at our clinic when she was a fellow and at UCLA showed that during her fellowship year, she assessed all the new patients that we saw in both locations who came to us for a diagnosis, for a second opinion about their diagnosis, and 18% of them were actually misdiagnosed as having MS. And you'd think, well, maybe that's because they didn't see a neurologist, but actually 80% of them had been misdiagnosed by neurologists, and 60% of them were on disease-modifying therapies, which are, as you know, expensive and have potential side effects. So this really raises the issue of why are these patients being misdiagnosed, and work that Andy Solomon has done, who's been very much involved in this area, found that it was mainly their MRI changes that were being misinterpreted as being demyelinating lesions. This is the non-specific white matter lesions that you see here, this NSWMA. These are non-specific white matter abnormalities, very common in things like migraine and as people get older with hypertension and diabetes. And they're misread by the radiologist and misinterpreted by neurologists as being demyelinating lesions. So could we do a better job at making the MRI more specific? And I'm showing you some very old school scans. These are proton density MRIs. This is what we used to use back in the day to assess MS lesions. And you can see that they're kind of white, fluffy lesions. They're very difficult potentially to differentiate from things like hypertension. So we go back to the future to Charcot's descriptions of MS lesions, and he defined those as having a central vein within the area of inflammation, which makes sense because this is where the inflammatory cells can migrate out into the white matter and result in the inflammatory lesion that we see as a hallmark of MS, a demyelinating lesion. So that would indicate that every lesion should have a central vein. And it turns out that using special imaging approaches, we are able to actually detect these. And this is work that Pascal Satie has done, as well as others, to demonstrate with now our new high-resolution imaging, we're able to see these central veins. You see the little dark dot in the middle of the white matter here. And we're able to see these in 3 different orientations and identify these lesions as having a central vein, which makes them very specific, much more specific for demyelination. And so here you just see some evidence here on very high resolution 7 Tesla imaging to give you a sense of how this really is pathologically specific. And I think just beautiful to be able to see this. So if you look at other diseases and other disorders that are frequently frequent mimics of multiple sclerosis, you can see the value of the central vein sign. So here in this study, 80% of lesions in the MS patients had a central vein, whereas opposed to these non-specific white matter lesions, only about 20% had them. And you can see these non-specific white matter lesions really don't have blood vessels nearby because they're mainly formed, we think, by ischemia, meaning a lack of blood flow. So they're far away from blood vessels. You wouldn't expect them to be surrounding a blood vessel. And then also in another study looking at another kind of demyelinating disease called neuromyelitis optica spectrum disorder, NMOSD, a smaller percentage of those lesions had central veins as opposed to multiple sclerosis, where over 92% had central veins in this study. The only other syndrome that has some evidence of a slightly higher CVS is Susac syndrome. So this is something that is a very rare disorder that causes white matter lesions and would need to be differentiated from MS, which is usually easy to do with those other paraclinical tests. So we're very excited about the fact that the central vein sign is now proposed for inclusion in the diagnostic criteria. The other area of interest is, again, going back to the pathology and then taking it into imaging, are these paramagnetic rim lesions or pearls. And you heard from Dr. Chitnis about the role of activated microglia as a sign of inflammation, especially in those secondary progressive MS patients. So what we found is pathologically, there are areas within the MS brain that have a rim of these iron-laden macrophages, microglia, and these seem to be associated with what you may have heard of smoldering inflammation or ongoing inflammation within the central nervous system. These seem to be related to this chronic inflammation and may be a marker of progressive forms of MS, may be a biomarker of poor progression. So this is taking this information that we see from the pathology into the imaging world. And here is a very important study that was done by Danny Reich and his group, looking at these lesions that were that you could detect in life using this high resolution imaging. And you can see using the susceptibility weighted MRI that you could see this paramagnetic rim. And when they took this, this patient ended up passing, and they were able to then verify pathologically in the brain tissue that these were iron-laden macrophages, microglia, that were surrounding the lesion. So we have this in vivo, ex vivo correlation, neuropathological correlation of these lesions. And they do seem to predict worse prognosis. So here you see the imaging approach that will allow us to identify these. And we think that the pearls have a lot of promise. First of all, for MS diagnosis, they're not seen in all patients with MS. It's about 40% overall, but probably higher in the early stages of MS. We think that they seem to be associated with disease severity. So if you look at cognitive dysfunction and physical disability, those patients who have these paramagnetic rims seem to have a faster progression and more disability. So we think it may be helpful for MS prognosis. So perhaps we can use this in the early stages to make a more definitive diagnosis of MS, but also to tailor our treatments to those who have evidence that they may do more poorly. So we'll be more aggressive with our treatments. There's still a lot of work to be done because these are not well understood in terms of how they evolve over time. Some of them go away over several years. They can disappear from the MRI. And so the effect of therapies on these and the long-term prognosis of these lesions is yet to be determined, but this is something that we're very interested, us and other groups, in looking at. So with that, I will just stop my presentation. I just want to acknowledge our group that we have at Cedars, in particular, Dr. Sathi's lab, who's done a lot of this work, as well as our collaborators and funders. And thank you for your attention, and I look forward to participating in the question and answer period.
Thank you, Dr. Sykott. I just want to highlight that some of these novel imaging markers Dr. Sykott presented at this neurological symposium about 18 months ago, and now they're being incorporated into our updated diagnostic criteria. So you heard it here first. It's my pleasure to introduce our next speaker. Dr. Hina Manglani-Terranova is a psychologist that works at the Massachusetts General Hospital, and I've had the pleasure to collaborate with her on both clinical and research topics related to mental health in multiple sclerosis, which is perhaps a neglected aspect of MS that she's been doing a lot of work on. So Hina, please join us.
Good morning. I want to start off and just thank two camps of people. One is you all for being here and being so curious to learn more, as well as the organizers, the McCourt Foundation, Dr. Clawwitter for inviting me to speak with y'all. So I'm very excited, and I don't tend to stay in one place, so I'll try to not block your view. I would like for this talk to be a little bit more interactive. So before I get started, you can see that my talk is about mental health, wellness, and MS. Raise your hand if you're willing and able, or make really intense eye contact with me, or just answer in your mind whether your primary care physician, neurologist, any healthcare provider has asked you about mental health. Okay. Now raise your hand if your partner or family member has said, maybe you should go talk to somebody. Okay. And raise your hand if you have thought about your own mental health. Okay. And then raise your hand if you're excited for fall in New England. Okay, great. Okay, so we're all on the same page then. So thinking about mental health, anxiety, worry, stress is very common. And I've had the fortune of seeing patients through Mass General, both in individual therapy, dyadic therapy, as well as group therapy. And these experiences of worry are quite common. And to illustrate, here is some things that people reported before starting therapy. MS is a sickness. It is not my choice. They said more. Hang on. I'm a little stuck. Let me go back. Okay. I'm still in denial because it makes me weak, vulnerable. I can't enjoy. I don't know what I want. Thank you. I'm tired of putting in so much. I wait for the foot to drop. This could be both physically as well as psychologically. What else is coming next? I protect myself from joy. So I want you to keep this in mind. We're going to come back to these folks at the end. So what I'm here to talk to you about today are the common mental health symptoms that people with MS and their partners can experience. And by partners, I mean a spouse, a romantic partner, as well as a family member, a child, as well as close friends, anyone that might provide some kind of support, whether it's practical or emotional. I'm also going to talk about what signs might suggest or indicate need for professional mental health support, where you can go to find mental health support, what coping skills you can start using today. So I'm going to take something I do in my therapy room, and I'm going to bring it to you all today. And what self-care could look like for you. Okay. So psychological distress is kind of this umbrella term we use to talk about anxiety and depression and trauma. And we know that people with MS experience depressive disorders 2 to 5 times more commonly than the healthy population, and anxiety disorders 3 times as more commonly. And even amongst others who have other kinds of neurological conditions, we see that anxiety and depression is reported at higher rates. We also know that MS is a condition that affects not only the person living with it, but also their caregivers, their care partners, close loved ones. And in care partners of people with MS, we see that 44% experience significant depression and 68% report significant anxiety. So we know that this distress, the worry, is interdependent. And mood and anxiety diagnoses predict disease progression. So this is why it's really important to consider how the psychological impact of having a chronic and uncertain illness can accelerate the disease. And as I was saying, distress can be interdependent and limit partners' ability to provide compassionate care. You can imagine if, as a care partner, you're having your own worries and concerns, but maybe you're hesitant to bring those up to the person with MS, to not add anything to their plate, and that goes vice versa. And so this distress is really important because it can lead to greater disability and worse quality of life. So one of the themes that we're hearing in the presentations today is early detection and early treatment. And in that vein, when I came to Mass General and I connected with Dr. Clawwitter, I was really interested in figuring out, well, why are some people able to better adjust to MS, where they don't experience clinical levels of anxiety and depression? And when I say clinical levels, I mean anxiety and depression that is dysfunctional, that's getting in the way of them living their lives in the ways that they want to. And so I went to the literature and I saw, well, there isn't a lot of focus in this early period after diagnosis. So once someone's diagnosed, what if we came in and we provided them with skills and strategies and tools that we know there's evidence behind in order for them to better manage the uncertainty, the distress that comes with MS. And so we designed the MS DIAD study, which is still ongoing, and there's some flyers with our faces on them on your tables. And this research is so that we can identify what are the factors that are associated with emotional distress in people with MS and their care partners in this acute period, in this first year after diagnosis. And based on those reports, based on what people report is difficult and challenging for them, what support they have, what support they need, we can identify coping skills that can help to mitigate the anxiety and depression. And then we can package this up and make it available, both locally and through partnerships with the National MS Society and other organizations. So this is some of our ongoing work. So if you have MS or you've been diagnosed in the past year or know of somebody else, I recommend sharing this because this is going to allow us to really target that early period. Now, going to whether the clinical piece, so that's some of the research that we're doing. As a therapist, it's very easy for me to say, yes, okay, I think you need to see somebody. But sometimes it's hard to figure that out. So I'm going to pose some questions to you. You can just answer in your mind. You can say yes or no, this is my experience or not. And these are some things that might indicate or are relevant for whether someone needs to see a therapist or not, or could benefit from seeing a mental health provider. Have I been feeling consistently sad, hopeless, or overwhelmed for more than 2 weeks? We all have a day where we're feeling down. Maybe it's raining outside, we don't really go anywhere, or the MS symptoms are pretty bad. That's normal. But if you're having a hard time getting out of bed, really talking on the phone, engaging with folks, doing things that you enjoy, that you're able to, and it's consistent, that might indicate that you might need to see somebody. Am I struggling to accept my MS diagnosis, or do I often feel angry or resentful about it? Acceptance is a really hard thing, and there's resistance to accepting it, because sometimes accepting it feels like, well, I'm resigning to it. And so if this is kind of a stuck point, you'll know it, you'll feel it. This might indicate need for further help and professional help. Am I having difficulty completing daily tasks due to my mental or emotional state, not just physical limitations? And is the stress of managing MS worsening my physical symptoms or triggering relapses? You may have heard that stress can put you at risk for disease progression. And so if you notice that you're having some of these symptoms, it can also indicate need for professional help. So then where do you go? So I'm sure a lot of folks here, if not all, know about the National MS Society. Well, first I should say, talk to your provider, your neurologist, your primary care physician. They will have a network of folks or can refer you to some local providers. You can go to the National MS Society. They have a new page now under resources, and you can find support groups and personnel, different clinics who have psychologists, social workers, licensed mental health providers. Or you can go to Psychology Today. So just to show you what this could look like, you can go on the page, you can enter your city. So since we're in Boston, put that in, and maybe you said, you know what, I want to find someone who I could see, I want a female, I want to see them in person, and I have, I have a chronic illness, so I want someone who works with folks with chronic illness. And then you can select other preferences, you put in maybe your insurance, if there's anything else that you want, you click on it, and then you go down and you click on Show Therapists. And then you can start reading about them. And maybe some folks have already been on this page. You go and you're like, oh, okay, I see someone. This person looks interesting. So you click on them, and then you read about their page. You see if you connect with what they're saying, what their approach to therapy is. And then if it seems relevant or could be helpful to you, you call them, or you send them a note explaining what is it that you're looking for. And on the bottom of this page, there are some questions to help you share what you are wanting to get out of therapy, kind of where are you feeling stuck. Okay. So let's say you are like, okay, I think it would be helpful for me to talk to someone, but what would I do there? So here are some of the things that I tend to work on with people adjusting to MS or living with MS. Tolerating distress. So getting comfortable with uncertainty, getting comfortable with the anxiety, the worry that comes with MS. Regulating emotions. Sometimes a lot of people I've seen in my clinic with disease progression, if they've experienced some difficulties with movement, with motor function, they get really frustrated. And sometimes they find that they have a shorter fuse. And so learning to regulate their emotions, become aware of them and regulate them in that moment so they don't experience that discomfort, that tension even more, or snap at someone else and then later regret it. Noticing and creating space from thoughts, that's a big one, and we'll practice that in just a second. Getting present. It's very easy when living with a chronic condition to not worry about the future, but I ask, when is life happening right now? So that's what we help to work on in our work together. Practicing acceptance. sometimes people come to me and they're like, well, Hina, I really want to accept MS. I've been fighting it for so long. And there's this notion that acceptance is binary. You either accept it or you don't. When in reality, acceptance is like falls on a spectrum. In any given moment, how much are you accepting your condition, your limitations, or are you struggling, resisting, fighting them? And this means it's a moment-to-moment choice that you can make. And sometimes knowing that you have that agency and how you can actually practice acceptance in real time can alleviate that burden and that tension, that resistance that one might feel. Improving communication and social relationships. So if you feel like you're retreating, as you might do in Boston in the winter months, and it's how do you stay engaged? How do you connect with people? How do you open up? How do you share? How do you find a community? And with that, engaging in pleasurable activities. Many times, I find people who are, very athletic, and it's this distinction between the life they used to live and the life that they're living now, and helping them find meaning and purpose, even now, even with physical limitations. And part of that work is figuring out what does self-care look like, which is very important, and the first thing that kind of goes out the window when we're stressed. Maybe it's playing with our pets, it's trying a new recipe, it's journaling, or it's meditation or practicing gratitude, or it's going to therapy. And so to give you a little bit of a flavor of what this could look like, one of the skills that I share in my work is this thing called hands as worries. So if you're willing and able, I invite you to take your hands and bring them to your face, just like you can see here in the picture, okay? And if you can, you might even wiggle your fingers, because that means that you're thinking. And our minds are usually talking a lot. Now imagine you have the thought, there's no hope for me. I'm only going to get worse. What's the point? Now imagine you go to see your neurologist, you go to see Dr. Clawwitter, Dr. Chitness, you go to see your provider. How much of the information can you get with your thoughts up here? Not that much, right? Now what if you go to your favorite restaurant with your favorite person in the world and you have the thoughts, I'm sick, I'm a burden. How much of your loved one can you see through your thoughts? Now, what if you bring your hand 6 inches from your face? Can you see a little bit more of the world around you? You can nod. Yeah. Okay. But still, is it occluding your view? Yeah. Now, what if you were to lower your hands? They're still going. Your thoughts are still there. But now, can you see your providers? Can you see your loved ones? Yeah. Now, this piece of lowering your thoughts is really hard, because our minds are like a conjoined twin. It sits on our shoulders and it talks a lot all the time. Oftentimes it's useful. Hey, pull over or get to the side, an ambulance is coming, we need to let them through. Or stop, wait for the walk sign before you walk. Those are all helpful things. Other times your mind says, you're a burden. Your life sucks. You're not the same person anymore. And in those moments, you can ask yourself, is this thought helpful? And if it's not, you can remind yourself, thoughts are not facts. And that's one way of lowering your thoughts. This kind of backfires at times, personally, when I have the thought that my partner should have walked the dog, and I come home and find that he has not. And I say to him, you should have walked Rohan. And he tells me, he's like, Hina, hold it lightly. And so this is something that you can use in your relationships too, if people get too fused or attached to their thoughts. Another skill, actually it's not a skill, it's more of a perspective, comes from this person. Does anyone know who this is? Does anyone know who Viktor Frankl is? Yeah? Okay. So Viktor Frankl was a neurologist, and this man was a Holocaust survivor. He lost his entire family in the Holocaust. And he comes out of it, and he writes a book on resilience, A Man's Search for Meaning. And I don't know about you, but I have no idea how someone who has faced such tragedy could come out of it and write about resilience. But then you read one of his quotes, and it makes sense. How? Between stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and freedom. So the S there, that stimulus, the situation, the scenario, that's what we're in all the time. And what he's advocating for is inserting that space. So the way I like to think of it is actually that we live more like this. Something happens and we have a knee-jerk reaction, right? It's immediate, it's automatic. So actually, it's a stimulus and reaction. But what if we can work on inserting a pause so that when we find ourselves in a situation that provokes us, instead of reacting, we can have a more intentional response, a more thoughtful response, a response that aligns with the kinds of people we want to be, the kind of person we want to be. So I think of therapy as this, as to what we can do in that moment. How do we help people insert a pause and figure out what are their values? How do they want to choose to live a full and meaningful life, even with MS? And it takes a lot of work. And folks who've done this have said this. Therapy was an eye-opener for me to realize my unhealthy thinking and behavior that have been feeding into my disorder. I'm starting to get it. I can spiral or respond to those thoughts in a more productive way. I'm not the reason for failure. I can say to myself, this is not true. Thoughts are not facts. When I let go of thoughts, those emotions don't stay as long. I can still do so many things. I can create my happiness. I can choose to be again. With that, I want to thank my mentors and give a huge shout out to Dr. Clawwitter for supporting my clinical and research efforts. I want to thank my research volunteers at Mass General and the funding sources for my work, including philanthropy, as well as the grant that I got from the International Neuropalliative Care Society to do the MS diet study. And here's some more information for me and Rohan, our dog, who loves walks. And we're ready for the Q&A now. Thank you so much for your attention.
Thanks, Hina. That was a really informative and practical talk. So I'm going to join or go back to my seat and moderate the remainder of our time of question and answers. But I thought I would at least pose a question initially that came in advance. But again, we'll be circulating both microphone and opportunities to hand questions forward. But the first question I wanted to pose, I guess, to the panel, but then also specifically to Dr. Chitnis, the question is, can you please address PIRA, which is a very terminology that's been coined more recently, that is progression independence of relapse activity, and the impact of PIRA on future treatments, both smoldering inflammation, which we've heard about in several of the talks here today. And then the question is, well, what percentage of people with MS have this progression independent of relapse activity? I'll start out with the last part of that. So there's at least one study, and keep in mind that there's different contexts for studying these types of outcomes, but this was a study that looked at over 1,000 people with MS that were initially diagnosed and then followed for an average of about 7.5 years. And this was also a more historical context. So kind of it's important to keep in mind, not in all patients that were diagnosed more recently with the treatment options that we have. But in that case, independent of relapses, about 25% of patients experience this disability worsening. But I'll start with Dr. Chitnis. I don't know if you can talk about your work in the CLIMB study, looking at this issue and how it relates then to what we think is sort of the underlying biology of MS.
Great, thank you, Eric. So what we do know is that MS patients can accrue disability by two mechanisms. One is called RAW, or relapse-associated worsening, meaning you had a relapse, then things got worse, your leg was weaker, and it stayed, it didn't remit. So that's called RAW. The other mechanism, as Eric has outlined, is PIRA, or progression independent of relapses. So that means that a relapse didn't occur that's leading to that disability worsening, and it seems to be due to a different biological mechanism. So I think going back to the RAW example, so RAW means, of course, a relapse occurred. That means a new MRI, gadolinium-enhancing lesion occurred. There was new inflammation that got into the brain, attacked a certain area, caused that, let's say, leg weakness. But in PIRA, this is independent of that acute new lesion. And our current treatments are very good at affecting and preventing relapses and hopefully preventing RAW. But the biology underlying PIRA is different, and it is largely associated with a couple of things. Biologically, those astrocytes that I mentioned, those supporting cells, and also the microglia within the brain, these are all supporting cells within the brain, are dysfunctional and they're inflamed. They're not doing their normal cleanup jobs that they should be doing, and they're producing bad factors. So those are really two key mechanisms of PIRA, or progression independent of relapses. So a new lesion is not forming, but these angry cells that are resident in the brain are getting inflamed. Those are leading to certain types of lesions like PRLs that Dr. Sykott had mentioned, as well as what we see on the PET scan with the activated microglia. There's also some other associated biological mechanisms. The axons and the neurons can be degenerating or dying, and that also is part of this. There's oxidative stress happening within the brain. So all of these are mechanisms of PIRA, and we're working to dissect and figure out one by one these different mechanisms because they might need different treatments. So hopefully that helps to explain PIRA. And also biological biomarkers might be helpful in explaining and giving us some understanding of PIRA in individual patients.
Yeah, thank you. I'll just segue to another question that came in advance related to cognition in multiple sclerosis. The question is, what ongoing research can help us better understand and cognition issues in MS, and then I think ultimately develop better treatments in this regard. So I think a lot of what the work has been done related to understanding cognition has actually been in the neuroimaging realm. And so trying to understand what is the underlying mechanisms of why some patients will develop memory difficulties or difficulties with attention or executive dysfunction. And I know Dr. Sykott has done work related to neuroimaging and specifically related to cognition. So I'll pose this question to you, Nancy.
Well, thanks for that. Yeah, so I think this is one of the areas of progress that has been made, at least as Dr. Chitnis was saying, 25 years in the field, same here. It used to be that people didn't think that patients who lived with MS had cognitive issues or it wasn't a big deal, and we know now that's not the case. So the studies have shown that the number and the volume of white matter lesions has been associated with worse cognitive function. And classically, that was thought of as this, what we would call subcortical changes. So hard time retrieving information. I know a lot of patients who live with MS have information processing speed issues. So the connections between areas in the brain are disrupted by MS lesions that are in the white matter. But we also know now that there are other parts of the brain that are impacted with MS, such as the cortical regions where the nerve cell bodies are living, as well as deeper structures. And we've looked at areas including the hippocampus, which is very important for memory formation. And it turns out that, unfortunately, MS can impact those areas as well. So it's a complex set of processes that are contributing to these memory issues. I would say the good news is that there are things that people can do to help improve cognition. Certainly all the things we recommend for our patients, like managing your comorbidities of hypertension, diabetes, getting enough rest, keeping your exercising regularly. And in fact, aerobic exercise is one of the best sort of neuroprotective therapies that we have currently. So while it is discouraging to think about the fact that the MS disease activity can contribute to cognitive dysfunction, there are other things lifestyle things that folks can do, including managing mood, which is another important factor related to cognitive function. So thanks for that.
Yeah, and to add on to that, at least at Mass General Hospital, we're very interested in this topic and have done a lot of work related to advanced MRI. And we have a special scanner at MGH that has this high, what we call a gradient set involved that allows us to better quantify these connections that Dr. Sykott was discussing, and then relate that back to what we're seeing in patients related to their clinical course and related to how patients will perform on some of these cognitive tests. Ultimately, with the ideas, in the same way that Dr. Sykott had told us about these imaging biomarkers that we use in the diagnostic criteria to develop better biomarkers to follow these, ultimately to develop and follow how patients are doing on treatments. That also relates to clinical trials and sort of what's new in the area of clinical trials. We had discussed, a large unmet need is related to the treatment of progressive MS. One of the big advances that was presented at this meeting in Copenhagen a couple weeks ago was a trial which is called the Hercules trial that was looking at a new category of treatments called BTK, a specific BTK inhibitor called tolebrutinib. And this is a question that came in, sort of what's the latest related to this specific treatment. I'll just sort of give the top line result from that study was that in a group of people with secondary progressive MS, this treatment reduced disability progression by 31%, which was it was a positive result and was encouraging, but I think is sort of prompting more